Good evening, everyone. Last class we discussed about the examination of breast and breast anatomy and investigations into the breast, including clinical examination, radiological examination, and tissue diagnosis. Now we'll discuss about carcinoma of the breast. Okay, breast cancer is one of the most common. It is the most common cancer in females in India. It is the most common cancer in females, followed by cervical cancer. Now, what is the risk factor? What are the risk factors of breast cancer? Risk factors. There are a lot of risk factors. We can divide them into modifiable and non-modifiable. So, whether they can modify the risk factors in their lifetime or they could not be modified. In the sense, in disease progression, these play a very prominent role. That is modifiable risk factors. The examples are obesity. Obesity is one of the important modifiable risk factor. Obesity, parity, the number of childbirths, which also plays an important role by estrogen exposure, duration of estrogen exposure. More the number of parities, lesser is the incidence or risk of malignancy. That is, it is inversely proportional to risk of cancer. Okay, then breastfeeding, which is also inversely proportional. Breastfeeding is actually a protective factor. The more more the period of breastfeeding, it is protective. These are modifiable. Next, age of first childbirth, hormonal replacement therapy, tobacco, alcohol, and radiation exposure. These can be modified. So, if these are the modifiable risk factors, what are the non-modifiable? They cannot be modified. So once it is there, then there are risk of breast cancer. What are those? Age, we cannot modify the age, or gender, which is more in females than males. Yes, males are also sorry, breast cancer can also happen in males. Ethnicity, family history of cancer, genetic predisposition. We'll talk about this in depth. Genetic predisposition, early menarche or late menopause. These two increases the duration of estrogen exposure to the patient. More the estrogen exposure, more the risk of malignancy. Okay. Then high risk breast lesions. Any benign or high risk lesions in the breast. We'll talk about during predisposing factors. Okay. So this is about the modifiable and non-modifiable risk factor for the breast. Then coming to the genetics of the breast cancer. Genetics of breast cancer. We know that breast cancer, which is the most common form of breast cancer, yes, it is sporadic breast cancer. It can be sporadic or it can be inherited. It can inherit from familial or it can be hereditary. What is the difference between familial and hereditary? Familial, they are they run in families, but they do not have any hereditary mutation that run in the family. Let's say BRCA, P53, any mutation, they will not be there. No identifiable mutation will be there, but they runs in families. Okay, but hereditary, they run in family with a mutated gene. So most common is sporadic. About 65 to 75% are sporadic, 20 to 30% are familial, and 5 to 10% are hereditary. Among this hereditary breast cancer, which is the most common one? Yes, BRCA mutation. BRCA in turn has BRCA1 and BRCA2 mutation, which is more common. BRCA1 is more common, which is 45%. BRCA2 is 35%. Okay. What are the other hereditary predispositions? BRCA. The other one is Lee-Fraumeni syndrome. You know what is that? Lee-Fraumeni syndrome, which is due to mutation in P53 gene. What are the other? Peutz-Jeghers syndrome. Peutz-Jeghers syndrome due to mutation in STK11 LKB1, or Cowden syndrome. Cowden syndrome, which is a mutation in P10 gene, or it can be Muir-Torre syndrome, which can be MSH2 or MLH1. Yes, what is this? We will see this MSH2 or MLH1 where we will see this in also in colon cancer. Colon cancer in the form of Lynch syndrome. And there are other mutations like ataxia telangiectasia in the form of M, or another unknown mutations carry up to 20%. So these are the mutations, genetic, familial or hereditary mutations that can run in families. Okay. Now we'll read more about BRCA in detail about BRCA mutation. What is this BRCA? Yes, BRCA mutation. It is again, before that, which is the most common mutation in breast cancer? Most common mutation in breast cancer is not BRCA, it is P53. Most of the sporadic cases have P53 mutation, which is followed by BRCA mutation. In BRCA, BRCA1 is more common than BRCA2. What are these BRCA1 and 2? Yes, we will see. BRCA1 mutation, anyone? Where it is? Which chromosome? BRCA1 gene is situated in chromosome 17 Q21, whereas BRCA2 is on chromosome 13 Q12. Okay, BRCA1 and 2. Both will cause CA breast. CA breast. What are the other malignancies associated with BRCA1 and BRCA2? BRCA1 associated with colon cancer, liver, and also sometimes prostate also. Whereas, oh sorry, we forgot breast and ovary, which is important, ovarian cancer. Whereas BRCA2, for some degree, it also causes ovarian cancer. Most importantly, prostate cancer. Prostate cancer is more in BRCA2 when compared to BRCA1. Pancreas, stomach, melanoma, and endometrial carcinoma. These are the malignancy profiles. Why these are important? If a patient has breast cancer, you are going to take family history. So if a patient has his siblings doesn't have CA breast, but they may have liver cancer or colon cancer or ovarian cancer, that also is a positive history which predispose the patient, the presenting patient, to BRCA1 and BRCA2. Okay. Now, what is the difference in CA breast, carcinoma breast, in BRCA1 and BRCA2? In BRCA1, the malignancy in BRCA1 is occurs in typically in younger age, before 50 years, and in BRCA2 it occurs after 50 years of age. If we see as subtypes, BRCA1 is usually triple negative breast cancer. Triple negative. We will talk about triple negative, what is triple negative breast cancer later. And if it is under BRCA2, it is hormonal receptor, that is ER or PR receptor, estrogen or progesterone receptor positive, hormonal positive breast cancer. Okay. If there is a cancer breast in right side of the breast in BRCA1, there is high risk of developing breast cancer in contralateral breast also. There is high risk of contralateral breast cancer, but here in BRCA2 it is low risk. And in tumor differentiation, whether the type of cells in the tumor are differentiated into breast cells, or that is mammary, ductal cells or lobular cells. In that BRCA1, the tumor is poorly differentiated, whereas in BRCA2, it is well differentiated. And the risk of risk of ovarian cancer is very high in BRCA1 when compared to BRCA2. Okay. Then male breast cancer. Yes, it is more common in BRCA2 compared to BRCA1. Okay. Then response to treatment. In response to treatment, here it is triple negative breast cancer in BRCA1, which is more sensitive to platinum based cancers or anthracyclines or chemotherapy. Let's say it has chemotherapy. Very good response for chemotherapy. And this is hormonal receptors, so this is very well responsible for hormonal therapy, like tamoxifen. Okay. And coming to the prognosis of the disease. Yes, it is worst prognosis in BRCA1 compared to better prognosis in BRCA2. Okay, this is about the cancer breast in BRCA1 and BRCA2. There are various risk models to assess this inheritance or risk of breast cancer, based on which screening programs are modulated. We'll talk about the risk assessment modules when talking about screening of the breast. Now, if the patient is having BRCA1 or BRCA2, can that cancer be prevented? Yes. Cancer prevention, there are various modes of cancer prevention in BRCA1 and BRCA2 mutations. Yes, one is continuous surveillance. Which, what happens if we have continuous surveillance? We can detect the cancer early. Early detection is possible by using whatever. It can be by self breast examination or MRI or mammogram. The surveillance can be any of these modes. Now, what are the other continuous or prophylactic surgeries are there? What can be done to prevent breast cancer in BRCA mutation? Prophylactic surgeries. Yes, you can remove the breast completely. That is bilateral prophylactic risk reduction mastectomy. Bilateral prophylactic risk reduction mastectomy. So it reduces the risk of breast cancer by 90%. 90% breast cancer risk is reduced, and about 40% ovarian cancer risk is reduced. What are the other surgery we can do? That is risk reducing bilateral salpingo-oophorectomy. Risk reducing bilateral salpingo-oophorectomy. By doing this, this is not done at early age. So it is removal of fallopian tubes and ovaries, both bilaterally. So what happens if we remove that? Reproductivity of the patient is taken out. So this is advised only after completion of the family. After completion of the family. And it is risk reduction. So if we do in the later when the patient is old or after menopause or after childbearing age, there is no probably no much benefit in risk reduction. So it is risk reduction, and it is usually done before 40 years. That is, it should be after completion of the family and before 40 years of the age. So what is the risk reduced? It reduces the risk by 90% for CA ovary and reduces 50% of the risk for CA breast. Okay, so this is about risk reduction surgeries. How else we can reduce the risk? One is surveillance, the second one is prophylactic surgery. What are the other modes? You can use chemotherapy, chemo prevention. It is hormone sensitive tumor. You can prevent the breast cancer using chemo drugs like tamoxifen. Okay, and I already told there are a lot of modifiable risk factors like obesity, alcohol, tobacco, everything, or hormonal replacement therapy. So lifestyle modifications also plays an important role. Okay, then screening programs for breast and ovary. Okay, then in high risk patients, you can also go for genetic counseling or testing. So these are the prevention modalities of breast cancer in BRCA mutated individuals. Now coming to the classification of breast cancer. Classification of breast cancer. Breast cancer, we divide it into non-invasive breast cancer and invasive breast cancer. Sorry, non-invasive or invasive. So in the breast we have ductules and lobules. So the cancer can happen in both of them. So it can be in non-invasive lobular cancer or non-invasive ductal cancer, which is also called as ductal carcinoma in situ or lobular carcinoma in situ. Now, presently in the newer editions, this lobular carcinoma in situ is not under in situ cancer. It is taken out from this in situ cancer, and it is a high risk lesion or pre-malignant lesion. High risk pre-malignant, it is treated as pre-malignant lesion or high risk lesion for breast cancer. So presently there is only invasive ductal carcinoma in situ in non-invasive. Invasive breast cancer can again be lobular cancer, that is invasive lobular cancer, or invasive ductal cancer. So, according to the WHO classification, this invasive ductal carcinoma, these both, these ductal carcinomas and lobular carcinomas, these are epithelial cancers, and this invasive ductal carcinoma is again divided into multiple one, which is invasive ductal carcinoma not otherwise specified. I'll talk about this later. Yes, the other one is based on the nuclear morphology or cellular differentiation. We divided it into tubular cancer, tubular carcinoma, mucinous carcinoma, medullary carcinoma, invasive papillary carcinoma, and it can be metaplastic carcinoma. It can be metaplastic carcinoma. So most common with in invasive ductal carcinoma, not otherwise specified. So it doesn't have any specific features like this tubular or mucinous or medullary or any others. So what are the features of these cancers? In invasive lobular cancer, it has a variable degree of growth patterns. Variable growth patterns, and it comprises of 10% of all breast cancers. 10% of all breast cancers. And the features on histopathology, it contains small cells with round nuclei, with scanty cytoplasm, and they form single line nuclei. Okay, and it has very good prognosis, and it is usually bilateral. So this is about invasive lobular carcinoma. What about invasive ductal carcinoma? Invasive ductal carcinoma, it forms cohesive mass. Invasive ductal carcinoma, it forms cohesive mass. It comprises of 80%. It is only 10%. It is 80%. Invasive ductal carcinoma is 80%. And it has various histological features based on which we divided into tubular, mucinous, medullary. Okay, in mucinous cancer or in tubular cancers, the cells are tubular, and which has good prognosis. In mucinous cancer, there is extracellular mucin. Extracellular mucin is there, and it has 2%. It has 2%, which has extracellular mucin, and it is also has good prognosis. Tubular cancer also comprises of 2%. Next, medullary cancers. Medullary cancers are soft, friable, and hemorrhagic masses. Soft, friable, and hemorrhagic masses. It comprises of 4% of all cancers. It has dense lymphoreticular infiltrate. Lymphoreticular infiltrate will be there. Lymphoreticular infiltrate. Okay. This is about medullary carcinoma, it is also having very good prognosis. Then talking about metaplastic carcinoma. Metaplastic carcinoma. It is a rapid increase in size. The characteristic is rapid increase in size, and it comprises of 2%. It is it is high grade and poorly differentiated. It consists of most of the undifferentiated cells, and it is having worst prognosis, which is the type of malignancy having worst prognosis, that is metaplastic carcinoma. Okay, this is about individual or different types of malignancies of breast. Now, while talking about BRCA1 and 2, I talked about some receptors. So we'll talk about other type of classification, that is molecular classification. Molecular classification. It is based on three types. It is based on two different tests, and which consists of four different markers, which is one estrogen receptors and progesterone receptors, which forms the hormonal receptors. The other one is HER2/neu, which is a growth factor receptor, HER2/neu. The other one is mitotic index, that is Ki67. I'll talk about everything later. What is this ERPR and what are these? They are hormonal receptors which present on the membrane of the cell. Which present in the nucleus of the cell. Nuclear receptors. These are nuclear receptors. Okay. Now, HER2/neu, it present on the membrane of the cell. It is a membranous receptor. What is this Ki67? It is also called as proliferation index, which means if you take a piece of a tumor, and when we examine, if we take 100 cells, 100 tumor cells, and count how many of them are dividing and how many of them are stable or static. So these are dividing. These dividing cells are called mitotic cells, which is called mitotic count. In this tumor, out of 100 cells, what is the percentage or what is the number of cells that are in dividing stage? That is proliferation index. That is percentage of dividing cells. Which means more the proliferation index, more the aggressiveness of the tumor. Now, how these are identified or are classified? Hormonal receptors, based on the immunohistochemistry, it is scored by using Allred score, which is 0 to 8. It is enough Allred score. Hormonal receptors are scored or defined by using Allred score. And HER2/neu receptor is a membranous receptor, which is denoted by immunohistochemistry, which has 0, 1, 2, and 3 scores. It can be 0, which means negative. No HER2/neu receptor is there on that membrane. Or it can be 1, means not amplified. 1 means non-amplified. Non-amplified means the receptor is not amplified. 2 and 3 are amplified. 2 is equivocal. We don't know. It is half of them are amplified and half of them are not amplified. And 3 plus or 3 is amplified. Which means if the report says 3 plus, then HER2/neu is treated as positive. But when it is 0 or 1, we can treat it as negative. If it is 3 plus, we can treat it as positive. What about this 2 plus? If it is 2 plus, we should do another test called FISH. What it is FISH? Fluorescent in situ hybridization. If it is positive, it is treated as positive. If it is negative, it is treated as negative. This is about HER2/neu, Ki67 et al. So based on this ER, PR, HER2/neu and Ki67, we have molecular classification. This molecular classification based on ER, PR, HER2/neu and Ki67. Okay. Now we divide them into luminal A cancers. Luminal A cancers which has ER/PR both positive and HER2/neu negative, and proliferation index is very low. Proliferation index is very low. So we know that while talking about BRCA2, BRCA2 is more having hormonal receptor cancer, which is having very good prognosis. So here BRCA1, which has only hormonal receptors and no HER2/neu positive and low mitotic index, it has excellent prognosis. It has excellent prognosis. Okay. Now the other one is luminal B cancer. Newer one has two types. One is major, the other one is minor. Most number of the cases and less number of cases. In luminal B, it can be either plus or minus. ERPR can be plus or minus. It can be positive. If HER2/neu is positive, it is uh, luminal B major. If HER2/neu is negative, it is luminal minor, but this negative should be with high Ki67. So this is also having good prognosis. And next we have triple negative breast cancer. Triple negative breast cancer. Triple negative ER, PR, HER2/neu. All three are negative. In this is an aggressive cancer, so mitotic index can be high. So this is having poor prognosis. The other one is HER2/neu enriched. HER2/neu enriched, which means hormonal receptors are negative, but HER2/neu is positive with a high Ki67, high proliferative index, HER2/neu index. We have one more which is called as Claudin low. Claudin low, it is also having everything as everything ER, PR and HER2/neu negative with a high Ki67 index. How we differentiate this triple negative breast cancer from Claudin low breast cancer? Yes, how we can? It has one cytokeratin markers, that is cytokeratin 5 or 6. Cytokeratin 5 and 6 are positive in triple negative breast cancer, and these are also negative in Claudin low. In Claudin low, everything is negative. That is about molecular classification of breast cancer. Any doubts? If you have any doubts, please let me know in the chat box. Anyone? Yeah. So we'll continue. Now, how we diagnose the breast cancer? Diagnosis. Last class only we discussed about triple assessment, which consists clinical, radiological and pathological assessment. So in clinical examination, we have history and examination, and in imaging, we have USG and mammogram. In pathology, we have core needle biopsy. Now, by doing this, how in clinically, how the patient will present to you. Presentation. How the patient will present. The most common presentation is lump in breast, which is the most common presentation. Where will be the lump? Most common situation is, most common region is upper outer quadrant, which consists of most of the breast tissue, which is usually hard in consistency and irregular in shape. About 50% of the cases are present in 50 to 60% are present in upper outer quadrant. What are the other symptoms? They can present with nipple retraction or nipple discharge or skin changes like ulceration or edema, that is also called as peau d'orange appearance. Peau d'orange appearance is edema of the skin of breast due to lymphatic blockade. So this is because of lymphatic blockade, the edema, the skin over the breast become edematous and look like an orange peel appearance. I will show the images. Yeah, I will show them later. The other one is skin nodules. There may be multiple nodules over the breast. Next, you should also inquire or ask about metastatic symptoms. The patient sometimes present with metastatic symptoms like one lymph node metastasis, which can be lump or swellings in the axilla or neck. Axilla or the neck, it can be there. Then where else? Distant metastasis to the bone, that is vertebra. The patient may have back pain. Then to the pleura, the patient may have pleural pain or cough, and breathlessness also can have due to pleura and lung, which will present as pleural effusion. Okay, so these are the symptoms the patient may present with. Now we talked about metastasis, how the local tumor in the breast metastasizes to axilla or to the bone or to the lung. How this spreads, that is spread of the cancer. Spread. There are importantly three routes of spread. One is through blood or through lymph or directly. Directly we call it as local spread, where all it can spread locally to the skin, forming ulceration. Okay, or locally to the, it can also locally spread to chest wall, posteriorly to the chest wall, involving serratus anterior or ribs or intercostal muscles. Through the lymph, it can spread to axilla, axillary lymph nodes, internal mammary nodes. Sometimes it can also spread to supraclavicular lymph nodes, or opposite side, internal mammary nodes. Okay. One important thing is, if there is contralateral or contralateral lymph nodes, either it can be axilla or internal mammary nodes. If they are enlarged, but there is no primary in the opposite breast is normal, but there are enlarged lymph nodes, which means it is metastatic disease. It is not locally disease, it is metastatic disease. Hematogenous spread through the to the bone, pleura, and lungs. Okay, and these metastasis can be, this bony metastasis can be, osteoblastic and also osteoclastic. Not always osteoclastic, it can be osteoblastic and osteoclastic, more osteoclastic. Okay, so if this metastasis involves bone marrow, it will cause leukoerythroblastic anemia. In the peripheral smear, if you see more erythroblasts and more leukoblasts, and the patient is having anemia, it suggests bone marrow involvement. Okay. Now, in case, I already told here, contralateral lymph nodes, involvement of contralateral lymph nodes without primary. What are the modes of spread? How they can? They can be hematogenous spread. Okay, or it can be primary without palpable mass in the opposite breast. We'll write it clearly. Yes, it is causes of, these are exam viva questions for final years. So the contralateral axillary nodes, contralateral axillary lymph nodes in breast cancer. So the patient is having tumor here, this axilla is positive, but is having nodes here also in the opposite side. So what are the causes for that? The important ones are due to hematogenous spread. Next, there is primary in the opposite breast, which can be palpable or impalpable. Next one, through internal mammary. There are internal mammary lymph nodes. They spread here. There are interconnecting lymphatic channels. Through that, there are these other side, opposite side or contralateral side lymph nodes are involved. That is through interconnecting lymphatics via internal mammary nodes. Sometimes subdermal lymphatics can also. There are lymphatics from the skin in front of the skin. Subdermal lymphatics can also spread to the opposite in front of sternum. Then it can be de novo in the lymph node by epithelial. It's an epithelial cancer. Breast cancer is an epithelial cancer. Epithelial embryonic cell rest. During development of the breast tissues which get these cells are trapped in the lymph nodes. They can turn into malignancy during embryonic development because epithelial embryonic cell rests trapped in lymph nodes during development. So these are the causes for contralateral breast cancer. Okay. Now we'll talk about tumor staging of breast cancer. Staging of breast cancer. In staging, we should stage the tumor per se, the lymph nodes, and whether there is any metastasis. So we stage accordingly. We tumor as if there is no tumor assessed or primary tumor cannot be assessed. We term it as TX. If there is no tumor, it is if there is no tumor, it is T0. And if it is TIS, it is in situ cancer. Remember, in situ cancer, I already told it is only ductal carcinoma in situ. LCIS, lobular carcinoma in situ, is no more considered as a non-invasive cancer. It's a high-risk condition that is predisposable to carcinoma breast. So this is TX, T0 and TIS. If it is Paget's disease, of the breast, it is written as T. Paget's. It is not the nipple, it is Paget's disease of the breast. Okay. Now we will see the tumor classification. That is T1. T1 is, earlier we know that 2 to 5 centimeter. T2 is, remember this, 2 and 5. T1 is less than 2 centimeter. T2 is 2 to 5 centimeter. And T3 is more than 5 centimeter. T4 we'll talk about later. We know all these things. T3, T4. T1 is less than 2 centimeter. T3 is more than 5 centimeter. But in the present 8th AJCC classification, they are not anymore using centimeter. They are using millimeter for precise measurement. Less than 20 mm. 20 to 50 mm. More than 50 mm. So this T1 is again divided into 4 subgroups. One is T1 microcarcinoma. T1 microcarcinoma, which is less than or equal to 1 mm. Remember, always this is in the greatest dimension. If the tumor is like this, the greatest dimension is taken, not the least dimension. And T1A, if it is T1A, it is less than 5 mm. It is more than 1 mm to less than 5 mm. T1B is more than 5 mm, that is 6 mm. 5 mm means T1A, more than 5 mm to less than or equal to 10 mm. T1C is more than 10 mm to less than or equal to 20 mm. So this is T1A, B, C. T2 is more than 20 mm, that is from 21 mm to less than or equal to 50 mm. It is more than 50 mm, that is 51 mm. It is starting from 51 mm. So this is T1, T2 and T3. In T4, we again divide it into A, B, C and D. T1A means chest wall involvement. Chest wall involvement. T1B is skin involvement. T1C is A plus B, that is chest wall and skin both. T1D is inflammatory carcinoma. Inflammatory carcinoma. So what are these T1A, T4A, T4B and T4C? Remember T4A is chest wall. Chest wall means it is involving ribs or serratus anterior or pectoral, intercostal muscles. Involvement of pectoralis major is not chest wall involvement. Remember, pectoralis major involvement is not chest wall involvement. And skin involvement. What are the three? There are three modes of skin involvement. One is ulcer. The other one I told lymphatic obstruction, that is pudgy orange appearance. The other one is nodules. I'll show those. Yes. So this is ulcer. Can you see? This is the ulcer. If you see, this is an operated case at our institute. There are multiple nodules here. These are skin nodules in transit from the, can you see? Yes, these are skin nodules. Okay, and this is pudgy orange peel appearance. Orange peel appearance. This is pudgy orange. Okay, only these three, pudgy orange, ulcer and skin nodules. Only these three forms skin involvement, that is T4B. Okay, and T4C is both A and B. T4D is inflammatory breast cancer, that is inflammation, redness of the breast skin, which is involving more than 1/3 of the circumference, more than 1/3 of the surface of the breast. Remember this, if it is involving more than 1/3 of the surface, it is called as inflammatory breast cancer. Okay, this is about tumor classification. What about nodes? What about nodes? Yes, we'll revise this. Yes, TX is no tumor or primary tumor cannot be assessed. T0 is no tumor. Okay. TIS is in situ carcinoma, which is usually a ductal carcinoma in situ. Lobular carcinoma in situ is not, is removed from the TNM staging. It is a predisposing lesion for carcinoma breast. T1 is less than 20 mm. Among that, there is T1 microcarcinoma, T1MI, which is less than or equal to 1 mm in the greatest dimension. T1A is more than 1 mm to up to less than or equal to 5 mm. B is 5 to 10 mm. C is 10 to 20 mm. T2 is 20 to 50 mm. T3 is more than 50 mm. T4A is involvement of chest wall. Pectoralis major is not, involvement is not as T4A. Okay. T4B is skin involvement in the form of three features, that is ulcer, pudgy orange or skin nodules. And T4C is both the chest wall and skin involvement. And T4D is inflammatory carcinoma, which means redness of the skin over the breast. There may be no palpable mass, but there is only redness of the breast, and it should contain more than, or it should be spread over more than one third of the surface. Okay. Now coming to the lymph nodes. Lymph nodes, that is NX again. NX is cannot be assessed. Nodes cannot be assessed, or nodes are not assessed. N0 is no nodes, no regional lymph nodes. N1 is ipsilateral mobile axillary lymph nodes, which is again level 1 and level 2. Remember this, level 1 and level 2 lymph nodes. Okay, that is N1. N2 we divide it as A and B again. N2A and N2B. N2A is ipsilateral fixed. Here it is mobile, it is fixed axillary axillary lymph nodes. Ipsilateral fixed axillary lymph nodes. What is N2B? It is internal mammary lymph nodes. Internal mammary lymph nodes, but axillary lymph nodes is not enlarged. Only internal mammary lymph nodes is enlarged. That is N2B. What is N3? What is N3? Again, it is divided into A, B, and C. Yes, A is infraclavicular lymph nodes. Infraclavicular. N2B is here 2B and 3B, both are same. That is internal mammary lymph nodes. Internal mammary lymph nodes. In 2, there are no axillary lymph nodes, but in 3B, we have axillary lymph nodes. Okay. And N3C is supraclavicular lymph nodes. Remember, all are ipsilateral. If there is contralateral, it is called as metastasis. So that is M, metastatic staging, M staging. M0 is no evidence of metastasis. M1 is distant metastasis by radiology or clinical, anything. Right? So this is about TNM staging. One important update here is there are two classes which are newly introduced. That is in N1. In N1 there is a new class which is in that is N1 microcarcinoma. Clinical N1, that is also called as micrometastasis. Micromets in axillary node. Micromets in axillary node. Okay, that is treated as N1 microcarcinoma. Then similarly for clinical M0 there can be I plus. It is I plus, which means there is no clinical metastasis, but there are microscopic cells circulating in the blood. Or it can be in bone marrow, or it can be in lymph nodes. So these are tumor cells, microscopic tumor cells. These are called as isolated tumor cells. So we just talked about two different types of cells. What are those? One we talked about one micrometastasis, which is clinical N1 micro. And we talked about second one, isolated tumor cells. These are the new terms introduced in newer edition, AJCC 8th edition. Okay. What are micrometastasis? Which is, it's a cluster of cells. It's a cluster of cells which is less than or equal to 0.2 mm. Remember, 0.2 mm. It should be less than or equal to 0.2 mm or less than 200 cells. A tumor deposit having less than 200 cells or less than or equal to 0.2 mm. It is called as micrometastasis. If it is more than 2 mm, 0.2 mm, but it is less than 2 mm, it is less than 2 mm, and it is more than 200 cells, they are called as, oh sorry, sorry, I just confused. Yes, micrometastasis, sorry, isolated tumor cells means it is less than 0.2 mm with less than 200 cells, only less than 200 cells circulating in the lymph nodes or blood. They are called as isolated tumor cells. Micrometastasis is more than 0.2 mm and less than 2 mm and more than 200 cells. So which is seen in N1 mic. It is metastasis, clinical M0 with isolated tumor cells, I plus. These are the two new stages introduced in newer 8th edition AJCC. Okay. Any doubts in TNM classification? Yes, last class we were talking about BIRAD scoring. Yeah, some people want to see mammographic images. We'll see this. Yes, mammography. We have last class we discussed about mammography. In mammography, we have two views, which is medial lateral oblique view and craniocaudal view. Okay, remember? Yes. See here, these are two views. This is medial lateral oblique. Always remember, both the breasts are imaged. Both breasts are imaged. Always, even for screening and even for diagnostic. Both the breasts are image. This is medial towards the sternum. It is towards the lateral. The axillary part, the axillary and upper outer quadrant is best seen in medial lateral oblique view. And this is craniocaudal views, above downwards. We'll see what are there. Okay. In mammogram, what are the things we see? In mammogram, what are the things we will see? The composition of the breast. We see the composition of the breast. We see whether there is any mass. We see the shape of the mass. We see the density of the mass or any calcifications. And we also see the symmetry. Based on this, we grade it into BIRAD scoring. BIRADs 0, 1, 2, 3, 4, 5. Okay, and the sixth one is biopsy proven, and we discussed about these. So we'll see what are the different compositions. See, in mammogram, it can be normal breast of an 40 or 30, 35 to 40-year female, which consists only fat. If it is fat, it is best seen in mammogram. Fat-rich tissue is best seen in mammogram. If it contains more of stroma, see this, this is fibroglandular tissue. Okay, see this is fibroglandular tissue, this thing. So this fibroglandular tissue will be seen as discrete densities. See here it is, there are large, more heterogeneous densities. What happens if there is any this stroma is there, fibroglandular stroma is there. If there is any mass, it is obscured by this stroma. So this stroma is more in young breasts, young females. So they have more fibroglandular stroma. What will happen? See here, this is fibroglandular stroma. More and more, the mammogram, if there is any mass here, we can't see. So mammogram is less sensitive. If there is more and more of fat and less fibroglandular stroma, that is more than 40 years of age, there will be only fat. The stroma will be less. In such cases, mammogram is highly sensitive. Okay, this is about composition. Now, mass can be seen as different shapes. Here, I will show one example. Yes, yeah. You can see a different intensity mass. You can see a different intensity mass. Okay, so you can see a mass on the mammogram, and it can be of different shape. It can be round, oval, irregular. Okay, and the margins can be irregular or lobulated or spiculated. So if it is regular, if it is clear, round, regular, yes, these can be benign. This can be benign masses. If there is irregular or lobulated or spiculated or indistinct margin, these suggest malignant lesions. These suggest malignant lesions. And while seeing whether the lesion is hypodense compared to the surrounding stroma, whether the lesion is same equally, the more the white, it is dense. Lesser the white, it is hypodense. So if there is calcifications, they will be seen brighter. They are hyperdense. Okay. Then architectural distortion. This is the normal architecture of the breast we saw here. See here, this is the normal architecture of the breast. If there is any irregularity, see here, there is something is pulling over here. If there is any architectural distortion, which is suggestive of malignancy. See here, there is architectural distortion. Okay, and symmetry. While seeing a mammogram, you should see both the sides of the mammogram. Okay, see, this is the right breast and this is the left breast. See here, there is no symmetry. It is normal, but in this side there is something obscuring. Some irregular densities are there. So there is asymmetry. See, you can see a mass here. This is asymmetry. Based on these compositions, and the last one is calcifications. Whether there are any, see, you can see here multiple skin nodules, skin calcifications is there, not in the breast. Okay, and here we have dystrophic calcification. Here we have a solid popcorn like calcification. Okay, here the mass is there, but surroundingly only rim, there are multiple calcifications in the rim, and a few along the vessels calcification are there, or sometimes it can be punctate calcifications. Okay, and in case of malignancies, there can be multiple powder like amorphous, or it can be fine small fine calcifications, or it can be linear. See here, it can be linear calcifications or heterogeneous, however it is. So heterogeneous calcifications also can be there. So these are the calcifications we see. Now, distribution of these calcifications. They can be distributed in a linear fashion, in a single line, or they can be distributed in a group in a single grouply fashion, or it can be diffused throughout the breast like here, or it can be to a region, a mass or upper outer quadrant or a region. It can be, or through a lactiferous duct segment. Only one segment is in. So these are the distributions of calcifications. Now we'll see what are the different how BIRAD scorings seen on mammogram. See here, both in both of these breasts, there is normal, there is no any hyperdensities, there is good fibrovascular stroma and good fatty tissues. There is nothing is there. It is normal breast, which is BIRADS 1. Okay. Here there is a well-defined mass is there. Here we have well-defined mass. See here the boundaries are normal, regular boundaries, no calcifications, no irregularities. Yes, it could be benign. What is the score we can give? BIRADS, sorry. Yes, no irregularity, no architectural distortion. We can give the score BIRADS 2. So it is benign. Yeah, what is the thing? What is the advice we give? Annual follow-up. Okay. Next, so this is, there are multiple calcifications are there, but there are some few, only few are there. So it is indefinite. We can't say there is no probable mass is there, but we can't identify anything. So they have confusion, but it is definitely not benign and it is definitely not malignant. So they give probably benign. That is BIRADS 3. Okay. So what is the BIRADS 3? We should 6 monthly follow up. Remember this. In BIRADS 3, what is the recommendation is we do at 0. Yeah, this is the 0. That is mammogram done now. We do at 12 months and 6 months and 12 months. 0, 6 and 12. If these three are normal or non-progressive, then what we do? We do yearly follow-up, regular annual follow-up, no 6 monthly. Okay. See, but here this is 0, but at 1 year the number increased. So it is high suspicious of malignancy. Stage accordingly, score accordingly. Okay, this is BIRADS 3. Next, BIRADS 4. BIRADS 4, radiologically we divide it into A, B, C and D, but it is not necessary. Any amorphous or linear or pleomorphic calcifications with an irregular mass is there, then we score it as BIRADS 4, which is high suspicious of malignancy. Yeah, what is the advice? Biopsy. Okay. And BIRADS 5 is an irregular lesion with spiculated. Can you see this? Spiculated margins. Spiculated margins is highly suggestive of malignancy. Highly suggestive of malignancy. So that is BIRADS 5. So this is about BIRADS. Anyone having doubt? Yes. Anyone having doubt? Yes, we saw about BIRAD scoring and staging and the management part. Management of CA breast will continue in the next class. It will be updated probably tomorrow or day after, whenever time is available. I'll continue. Any doubts? Please let me know in the chat box. We'll clear it. Or you can also ask me in the group. Thank you.